So now I have the pleasure of introducing Dr. Carrie Dimitrilis. Carrie is an interdisciplinary scholar specializing in qualitative methods and the ethics of childhood. She completed her PhD at University of Toronto in 2019, where she studied human development and bioethics. She then spent a year as a postdoctoral fellow at Vanderbilt University's Center for Biomedical Ethics and Society, where she also trained as a clinical ethics consultant. In the fall of 2020, she will join the psychology faculty at the University of the Fraser Valley in Canada as an assistant professor. So I want to welcome you, Carrie. Carrie's talk is titled Performing Autonomy, Culture, Capacity, and Compliance. I'm going to turn over to you.
Thank you all so much. It's wonderful to be here with you all today. Just going to get my slides up. So there's just a slight change in title for the title that Gail announced. So the talk today is going to be called Performing Autonomy, Pediatric Choice, and Pediatric Voice. And it's a pleasure to be here with you all. As Gail said, my name is Carrie Dimitrilis. I'm a settler scholar speaking with you this afternoon from the traditional territory of the Mishi-Segig Anishinaabe in Southern Ontario. So this talk is going to focus on questions of autonomy, choice, and voice in acute care pediatric settings. And in a lot of ways, it picks right up on some of the themes that Franca was bringing to the surface, because I'm interested here in the way young people's capacity to make their own medical decisions is assessed, in the expressions of voice that young people must produce in order to be heard in pediatric space. This ties closely to broader interests that I have in the way that choice is constructed in pediatric medicine more generally. Who is seen as capable of choice? Which choices can be made? Which choices cast doubt on a person's ability to choose? I come to these questions through my ongoing research, which explores biomedical refusal, situations in which young people and families attempt to resist or to refuse forms of biomedical treatment. And today I'm going to share with you one such case, in which an 11-year-old Mohawk girl attempted, along with her family, to refuse chemotherapy in favor of traditional Haudenosaunee healing practices. I ground my discussion in 5 years of ethnographic engagement with this family, as well as interviews with the many physicians, nurses, social workers, healers, clan mothers, elders, and state agents who became entangled in her care. She's chosen the name Lyra for this project. All right. Child Protective Services received a phone call reporting Lyra as a child in need of protection at 4:45 p.m. on a Wednesday in August. The social work case notes read, quote, Dr. Chelsea Bernard called to make a report concerning Lyra, an 11-year-old Native girl who's diagnosed with acute lymphoblastic leukemia. The family has chosen to discontinue the chemotherapy in preference of Native medicine and treatments. Lyra's condition has an 85% chance of full recovery. However, Dr. Bernard reports that without chemotherapy, she has weeks to months left to live. Social workers from Child Protective Services began their investigation into Lyra's case the following day. Interviewing family members and the clinical team, they learned that Lyra's family had repeatedly requested permission to perform healing ceremonies and to bring medicines prepared by healers into the hospital. Some healthcare providers seemed willing to allow it. Others refused or in other ways worked to resist these efforts, and the relationship with the family rapidly deteriorated. During their investigations, a major point of contention arose between Child Protective Services and the hospital. Was Lyra herself capable of making the decision to refuse chemotherapy? According to Ontario law, all patients, regardless of their age, are presumed capable of making medical decisions unless there is evidence of their incapacity. The hospital asserted that Lyra was incapable, and so Child Protective Services pressed them for evidence. In response, the hospital articulated 3 arguments, which I consolidate here from social work case notes, court records, and my own interviews. The first argument offered by Hudson Children's Hospital was that Lyra was too immature to make the decision for herself. For example, in materials submitted to the courts, the lawyer for the hospital characterized Lyra as, quote, lacking the maturity even of typical children her age. Similarly, in an interview, one of Lyra's oncologists pointed to her fondness for drawing during important meetings as, quote, a little insight into her level of maturation. However, Denise Johnson, the social worker at Child Protection who managed Lyra's case and who is herself Mohawk, tells me that she had serious concerns about how the assessment of Lyra's capacity was taking place. Quote, her doctors kept telling me she does not have the capacity to decide about chemo for herself. And I kept asking, who did the assessment? What language was used? Are you aware that Lyra's first language is Mohawk, right? Like, I just don't understand how they could assess the capacity of a child outside of the context of her language and her culture. Denise's insistence that Lyra's capacity for mature decision-making must be understood as linguistically and culturally mediated is supported by research in the anthropology of childhood and human development, which indicates that in many societies, it is social events or achievements valued by the community that are the important markers of young people's maturity, rather than their chronological age. At 11 years old, Lyra is the third youngest of her 11 siblings. She's regularly called on to provide sophisticated care for her brothers, sisters, nieces, and nephews. I've seen her prepare meals, care for infants, help her 16-year-old brother with Down syndrome to communicate and navigate a range of social interactions. Lyra is active in her Longhouse community. She attends a Haudenosaunee cultural immersion school where her mother is a teacher and a Mohawk language specialist. She competes in lacrosse and in Longhouse dance and was recently awarded special recognition for her language skills at an international conference on Indigenous language revitalization. Here we see, as Carnevale and Teachman have argued, how a binary construction of capacity as either present or absent belies the relational complexity of pediatric choice. It is possible that if Lyra's capacity was assessed by someone who was in a position to recognize her expertise as a bilingual caregiver, teacher, and community member, that these important social achievements and markers of relational maturity could have been brought to bear on discussions of her capacity to make medical decisions. It is clear, however, that the construction of Lyra as, quote, lacking the maturity even of typical children her age, relies on a culturally particular conceptualization of maturity and of typical children that does not take Lyra's full range of skills and expertise into account. The second tack that was taken by those arguing for Lyra's incapacity was to position her as too dependent to make medical decisions for herself. These arguments tended to underscore an absence of autonomous voice. For example, the lawyer for Hudson Children's Hospital noted that Lyra, quote, did not ask questions, deferred all decisions to her mother, and did not exert any independence. These constructions bring ideals of freedom and self-rule embedded in principlist accounts of autonomy to the surface. Arguments that emphasize Lyra's dependence turn on a logic of autonomous liberty. The idea that for a choice to be free, it must be made in a way that is free from controlling influence. Stressing Lyra's deference to her mother and her failures to speak up for herself or exert her independence are intended to cast doubt on whether Lyra's decision about chemotherapy would be made under requisite conditions of non-control. The condition of autonomous liberty puts young people who are materially and emotionally dependent on adults in a double bind. On the one hand, it is precisely because adults exercise so much power and control in young people's lives that opportunities should be created to ensure children are not coerced into actions they do not themselves wish to pursue. On the other hand, in assessments of their autonomy, these dependent relationships can be constructed as evidence of young people's incapacity to make medical decisions for themselves. Expectations of autonomous liberty, thus, require young people to perform an individualism that is at odds with the material conditions of their lives. This brings us to a further problem. As with constructions and assessments of maturity, independence is not a self-evident good. Rather, independence is a culturally particular social value that is not associated with the making of good decisions in all settings. As Lyra's mother, Kahunsio, explained, quote, I think where they misstepped is not having any awareness of cultural relationships between an Indigenous mother and an Indigenous child. In our culture, children speak to their parents. I noticed that Indian children kind of keep their tones low, kind of whisper in their parents' ears, and won't speak in front of other people. Those are cultural norms that are abnormal to Western culture. They want you to like speak out and make eye contact to get their respect. And that's just not what Indian children are going to do. Capacity assessment then requires a special kind of giving voice. To be found capable, young people must enact a culturally particular social norm of independence, which is encoded via embodied practices like speaking out and making eye contact. Young people like Lyra, who have not been socialized into these performances, may then be at a disadvantage for establishing their capacity. The final argument for Lyra's incapacity was, as one of the lawyers I interviewed put it, quote, "People need to be rational. Rationality is choosing life when you have a 98% cure rate and certain death on the other side." The concern underlying this statement is that refusing chemotherapy is an irrational decision, one that signals Lyra is not capable of taking part in the medical decision-making process. This argument brings us squarely to the intersection of capacity and compliance. There are two dimensions that I'd like to consider. First, young people's capacity to make autonomous decisions is likely to be the topic of conversation only if they or their families are non-compliant. If the patient and the parent present as agreeable and follow the physician's recommendations, then the question of who is making the decision can remain pleasantly in abeyance. The second, and to me more troubling intersection of capacity and compliance, has to do with the way non-compliance can itself be construed as evidence of incapacity. The concern here is that the act of challenging the physician's authority and/or the biomedical epistemologies on which it rests can be used as evidence that a patient is irrational and on these grounds incapable. This is particularly troubling since not all patients and families are equally likely to be read as irrational in biomedical settings. Research shows that it's patients and families who face systemic discrimination in the healthcare system more generally that are most likely to be interpreted in this way. Taken to its most troubling extreme, then, these intersecting factors create the conditions for already marginalized patients to be disproportionately forced into treatment against their will. You may have noticed that one important voice is so far absent from my discussion. What did Lyra think about all of this? When I interviewed her about these experiences nearly 2 years after her initial diagnosis, she told me, quote, "For some reason, they just didn't want us to do Indian medicine. They just said, stay on the chemo. And when we kept asking, they said that I wasn't old enough to choose my decision." I asked, "Do you remember that conversation?" She replied, "A little bit, but sometimes for those kind of conversations, they would like take my mom outside into the hallway and stuff so that I couldn't hear what they were saying." I asked her, "How did that make you feel?" She told me, "Not really worried because I knew my mom would tell me what they say later, but it was getting pretty dark over me because they just kept taking her out and talking to her and saying I wasn't old enough to choose my decision." I asked, "What do you think about that? Do you think you were old enough?" Lyra takes some time to consider before telling me, "I was ready to choose my decision, but they just wouldn't let me." Reflecting back on her experience, Lyra narrates herself as a person capable of choice who was living under conditions of misrecognition and constraint. She experienced these multiple exclusions as a feeling of darkness gathering over her. Lyra is not particularly outspoken, but she enacts her agency in other ways. Over the years, I heard many stories about the diverse ways she and her sisters thwarted and outsmarted the healthcare providers at Hudson Children's Hospital. These acts of resistance took many forms. For example, sneaking Indian medicine, as she calls it, into the hospital disguised as iced tea, or eavesdropping on conversations in the hallway that her physicians did not want her to hear. Other forms of resistance were more metaphysical in nature, stemming from Lyra's dreams and her increasingly regular encounters with the spirit world. These forms of resistance are complex and they merit their own discussion. I I bring them up here to underscore a point made by Teachman and others who work in childhood ethics. The voice may articulate in unexpected modes, and that it would be mistaken, dangerous even, to view young people who cannot or do not speak out as docile or as incapable of shifting the conditions of possibility for their care. When a young person refuses biomedical treatment, their capacity to make autonomous medical decisions is called into question. To be clear, I'm not arguing that this is necessarily a bad thing. I think we do have a collective responsibility to keep young people safe, and that sometimes paternalistic coercion is appropriate. What I've argued here is that culturally particular understandings of childhood, agency, and rationality underpin our assessment of young people's abilities. I presented a theorization of voice as performance, a set of embodied practices and verbal strategies that young people must enact to be found capable of deciding what happens to their own bodies. Finally, I've explored the way power circulates at the intersection of capacity and compliance, raising concerns that young people who face systemic discrimination in healthcare institutions may be more likely than other patients to be understood as incapable. There's so much more that I would like to tell you about Lyra's story, but for now, I'm over time, so I'll just say briefly that in the court case that followed, the judge ruled that as Indigenous peoples, Lyra and her mother have a constitutionally protected right to practice Haudenosaunee medicine. This ruling enabled Lyra's family to connect with a team of oncologists at a different hospital who were willing to partner with the family's primary healer. The hybrid healthcare plan they created, one which combined biomedical and Haudenosaunee healing practices, was successful in returning Lyra to health and well-being. Today, she's 17 years old and her cancer is in permanent remission. Thank you.
Thank you, Carrie, for that very moving and eloquent talk. It was lovely to hear a little bit more about your work. I'm going to shift now to asking some questions. And to begin, wonder if you can tell us a bit more about the process of doing the research. You mentioned that you engaged in observation over a period of years. So maybe you could tell us a bit more about how you elicited and represented Lyra's
Yes, thank you
voice.
for that question. Maybe I'll take it in two parts. First, the question about eliciting voice, and then the part about representing it. So as you mentioned, a big part of eliciting voice for me in this project was just spending a lot of time. This was my doctoral fieldwork. It took place over the course of 5 years. It was not ethnographic immersion in the sense that I didn't live in Lyra's community, but it was intermittent over those 5 years and regular, that I was invited out to the reserve community where her family lives for a range of, doctor's appointments, but also just family gatherings and community events and political gatherings and so on. So the first part of eliciting experience in this case was just spending the time to develop those kinds of reciprocal relationships and trust. The second, more specifically attuned to Lyra herself, had to do with following her interests, as I know a lot of folks who work in qualitative methods with young people suggest. So in particular, she loved art and loved doing art projects. And every time that I would go to visit with her, she has a lot of brothers and sisters and nieces and nephews, and there was always a ton of kids at the house. And so I got in the habit of just bringing projects with me, and we would sit down and there would be a lot of kids and we would dive into some project. And through that process of getting to know each other and developing trust, there was a kind of communication that was possible, that was made possible by those activities that I don't think would have been there if the first time we met, we sat down with a recorder in between us. So that's in a way also about the luxury of time. And I guess the third aspect of eliciting voice is that I had a really extraordinary doctoral committee who pushed me to look for forms of agency and other kinds of ways that voice may be expressed. So that's to the question about how do you elicit voice. The question about how to represent it had really additional complexities for me in this project as a settler scholar, in particular, navigating the politics of representation was one of the most fraught ethical dimensions of this work. And my approach has been to really involve Lyra and her family in every aspect of the project. So not just in coming up with research questions and spending time together, but also having a lot of involvement from them when it comes to analysis and representation. So one of the reasons that I was reading from a paper during this talk rather than just speaking with you fluidly is because when I prepare a talk and when I write a paper for publication, I send it to the family and ask for their feedback and guidance. And so far, that has been a project that they're very interested in continuing to engage in, although it may change over time. However, I will say that so far, that engagement has primarily come from Lyra's mother and some of her older siblings, and less so from Lyra herself, who, as I mentioned, is 17 now, despite invitations for her feedback. And so something I'd be really interested to hear from other panelists and other people who are listening right now, if they're interested in getting in touch, is ideas that they have for ways to engage young people in processes of representation after the sort of work of data collection in the project has come to a close and the relationship has shifted. So I would love to hear more from others about processes of co-representation.
Thanks. Here's a second question. Someone has written, I appreciate your argument that we need to think about capacity and voice as culturally and linguistically mediated, but clinicians not usually have the time for the kind of ethnographic immersion that you enjoyed as a researcher. Can you say more about how these suggestions might be implemented by clinicians in real time?
Yes, thank you for that question. So of course, clinicians don't have the same kind of time that researchers do to do this work of creating a relationship that Dr. Carnevale so beautifully described in his talk. But I do think that there are some things that clinicians can do to try to elicit some of the relational complexity and to situate young people's responses within their kind of cultural and family context. So really simple questions like, tell me about the responsibilities that Lyra takes on in the family. Tell me how you know that a child's ready for big responsibilities in your community or in your family. Those are some questions that clinicians could ask a parent or a sibling or someone else who comes with a young person. And then also questions to the young person themselves. How can I make you comfortable in this setting? Or is there a way that you usually like to have these conversations? And certainly if they exhibit a comfort doing something else while they're talking, for example, drawing or other ways of engaging, trying to have a patience and a tolerance for that rather than reading that as immaturity as happened in this case.
Okay, here's one more. What do you think about the gender aspect of autonomy, choice, and voice in general, and in Lyra's story in particular?
Thank you for that question. This is actually something that Lyra's mother really brought to the surface. One of the things that happened when the relationship broke down between the healthcare providers and the family was that when Lyra's mother started saying, we really want to incorporate our own healing traditions, and otherwise we're gonna say no to chemotherapy. Immediately the physicians were asking, well, what does your husband think about this? And where's Lyra's father? And trying to look for other sources of authority there, which makes sense from the healthcare providers' perspective because according to the healthcare consensus. So if they could get a yes from dad, then they could circumvent the no from mom. And that was the route that they tried to take. And this was interpreted by Lyra's mother and by her aunties and by the elders and by so many people who became entangled in the case as a real moment in which the relationship was kind of irreparably damaged. And if this is a question that's of interest to you, maybe we could get in touch, because there were a lot of conversations that I had with Lyra's mother about the gendered responsibilities of women in Haudenosaunee culture and the way that this presumption that her father would be better able to speak to her best interest than the mother would be was interpreted and understood by the community. So I would love to get in touch and say a bit more about that if you're interested. Oh, Gail, I think you're muted.
That's bound to happen at some point. I did notice that your email has been posted in the chat. So the person who asked that question, and anyone else as well, if you're looking to contact Carrie, her email's there. I think we have time for just one more. How do you balance your ongoing interest in the research and Lyra's possible disengagement, which might be due to her wanting to move on from her illness?
I mean, I think my approach is to not push her. I mean, if she doesn't want to, I mean, create opportunities for her to get involved, try to create varied opportunities. So last summer I had the privilege of putting together a conference that was co-organized with Lyra's mother and their primary healer that brought together Haudenosaunee healers and biomedical healthcare providers from the local community for a day of collaboration and relationship building. And one of the groups who we invited as speakers was the Youth Council on which Lyra sits. And so creating different ways for her to engage. So it doesn't necessarily need to look like, you know, reading a paper that I send and giving me comments. It can also look like speaking to her experience in other ways, or just, you know, bearing witness to those experiences in other ways. So trying to create a variety of opportunities, but then not pushing it. I mean, I would love for her to be engaged. I think that she knows that and knows how to contact me at any time if she wants to reach out and say more or say less or ask me to change the way that I'm representing it. I think that she knows how to do that. And apart from that, I'm just thrilled for her that she gets to be 17 and, you know, let that be her life.
Yeah. Thanks. I think we'll end the questions there.